Thank you very much, and thank you, Jean-Pierre, for inviting me again. Between April 2010 and February 2011, in 10 different centers, non-expert centers using first generation of device with no learning curve, we treated 23 patients, 4 female and 19 male, mean age 77. They all suffered from wide and extensive thoracoabdominal aneurysms, and they were treating with multilayer stent. All these patients have been reassessed up to 3 years independently by a core lab. We looked at primary efficacy endpoint, aneurysm exclusion from circulation, branch collateral patency, primary safety endpoints, all cause of mortality, secondary endpoints, type 1 and 3 underleaks, etc. All these patients were very high risk for surgery. That could be illustrated by 30% rate of renal insufficiency, and moreover, 65% of these patients have had a previously attempt of treating that disease, either surgically or with endovascular stent. They were, as I said, type 2 and 3 underleaks. And the procedure turned out to be easy with a few fluoroscopy, contrast volume, blood loss, and short procedure. And at 3 years, because I'm reporting the 3 years results, we had 7 deaths out of 23 patients, 188 from cancer, 1 from peritonitis. There were 3 underleaks, type 1 and 3, and 2 from unknown reasons. In addition to these, we had 2 patients explanted, 1 after resuming chemotherapy for his lung cancer, 1 for the non-corrected type 1 underleaks, and 3 lost to follow-up at 2, 12, and 27 months. Out of the 23 patients and the 11 left, we did not observe any spinal cord ischemia, no aneurysm rupture, no migration, stent fracture, no respiratory neuroperipheral complications. At 36 months, in 11 patients left, we had 1 occluded branch, and this patient was diagnosed with a Houghton disease. And we had a type 3 underleak in 1 patient. Out of the 11, we had 10 patients with the aneurysm excluded, and of course the one with the underleak who was not treated. There was no exclusion of the aneurysm. All the stents remain patent. And when we look at the change of size, if we take a 5 millimeter threshold, we had an increase of the aneurysm at 3 years in 3 patients. 7 remain stable, and 1 decreased. All residual flow were less than 10%, except 1 patient. And if we want to think about the evolution of the diameter, of course, we had to take off the patient who had the underleak. So we were a bit puzzled because sometimes it increased, sometimes it decreased, and sometimes it was stable, and we tried to understand. And it appeared that when we take a 70 millimeter cutoff, in other words, if you treat too big an aneurysm too late, it wouldn't work. In other words, the patient who was before being treated, which size of the aneurysm was under 70 millimeter, it worked, and it didn't work if the aneurysm was too big. And that was probably because of the lack of elastic recoil. So, in conclusion, the aneurysm exclusion was obtained in 10 out of 11 patients. All the stents remained patent. We had a primary branch patency of 51 out of the 52 covered visceral branches, with no migration, no fracture, no kinking, with 1 underleak. And this is very important. This patient have to be reassessed because more than 1/3 of the patient needed, over time, a second procedure. The maximal diameter was stable in 7 patients, increased in 3, and diminished in 1. The residual flow volume went down from 14 to 5%, the thrombus volume went up from 45 to 62%. We didn't have any paraplegia, no aneurysm rupture. And these are two examples, and we have at your disposition the 11 patients that were assessed at 3 years on this very old cohort. And in conclusion, the aneurysm thrombose with a residual flow, when they are correctly treated, at 3 years, 7 out of 11 patients had a stable aneurysm diameter. And when you treat the aneurysm too late or too big, it doesn't work. Thank you very much for the privilege of giving you this address.
Thank you very much, Claude. Any questions from the audience? Yes?
Thank you. Did you notice any difference concerning results according to abdominal or thoracic aneurysm?
No, this, by protocol, it was only designed to treat the patient at risk of spinal cord ischemia, so thoraco-abdominal aneurysm. We did not treat any, it was type 2 and 3, no abdominal on this series.
Professor Mastracci?
And to prevent another question, we did not treat any other patient ever since. We just did this series, and we're trying to understand over time what happened to this patient before issuing any recommendations.
Sir, if the aneurysms in your series continue to grow, it doesn't appear to me that you've actually changed the natural history of disease. 60% of patients either die or require re-intervention within 3 years. How can you justify putting these patients through this stent graft procedure if it's not really changing their natural history?
I'm not justifying anything. I'm just giving a raw data, ma'am. And I do agree that in this new paradigm, we're trying to understand what's happening, and we're just reporting the data. So I'm not issuing any recommendations. I'm not justifying anything. I'm just saying that if you put this this graft, and if you do not reassess your patient, if you do not expose your patient to correct anything, then you're not doing a big job. Now, we showed in the surviving patient that you do not, as you say, change the natural history of the patient if the aneurysm is too big. In other words, to make it short, over 70 millimeter, this is not an indication.
Can I just say one quick comment? Have you considered doing a study on the thoracic aorta? At least you have the argument that there may be less risk of spinal injury, and you do have an alternative in case it fails. The problem of the arch and the thoracoabdominal is that's really no other alternative. You know, it basically determined that the patient will either have an explant or else.
I'm sorry, this protocol was imposed by the government, so we didn't have any choice of limiting the experience to thoracic. In other words, these patients have been included if they had absolutely no other options. No surgically, they had to be designed by the vascular team. No other option. If on any type of any of these patients, 23 patients, there had been any possibility of stent fenestrated or open repair, they couldn't come into the study.
Yes, thank you for an interesting presentation. I have Martin Björk from Uppsala, Sweden. I have a question. Isn't it necessary to have a control group in such a study? Because if we don't randomize the patients to treatment and non-treatment, we will never know if this is better than the natural history. It would be, to me, it's very difficult to evaluate this experience because there's no control group.
Okay, I'm going to talk to our Ministry of Health to do another study.
Well, it's just because otherwise we don't really know these patients, what's happening to them. Wouldn't you agree on that?
This is still a very interesting area, and I remain unconvinced and somewhat optimistic, but cautiously so. What was the average size of the aneurysms less than 7.2 that were treated this way?
65.
Okay, I think we could go on because this is very exciting, but it's time, so I give the word to the chairman to conclude. Thank you very much, Claude.
Thank you.
I'm not the chairman, so thanks, Martin. Just thanks to all the speakers for the excellent talks.